Good afternoon and welcome. We are delighted that you are joining us for what we hope will be a very informative and inspiring discussion about strengthening Irish African partnerships in palliative care. The webinar is hosted by the Irish Global Health Network with the support of the African Palliative Care Association. While people are joining, it would be great if you could put into the chat box, which is down below, where you are joining us from. Let me introduce myself. I'm Jean Callanan, and I'm an advocate for dying well, who's particularly interested on how we in Ireland can help address the considerable gaps in palliative care in Africa. I'm also the current chair of the Irish Hospice Foundation. I am joined today by a wonderful panel of talented and committed people who are coming from lots of different backgrounds, and they're all people who are making a real difference in improving people's lives. I will be interviewing each of them individually about their work, and before I interview each of them, I will actually introduce them. At the end, we will have 15 minutes for panel discussion. As we go, please drop any questions or comments you have into the chat box, and we will address as many of them as we can during that panel discussion at the end. We also have some resources that we will add into the chat box, and you might have others that you would like to add in. Our goal is to make this session as interactive and as informative as possible. We couldn't have anyone better to give us a picture of palliative care as it is in Africa today than Dr. Eve Namisango, Executive Director of the African Palliative Care Association. I first met Eve 3 years ago when I visited APCA in Kampala, and her energy and commitment to palliative care in Africa shone through. She is an expert in palliative care and policy and has co-authored lots of international articles on palliative care in Africa and led numerous research studies. So you're very welcome, Eve.
Thank you, Jean.
Can I start by asking you to paint us a picture of access to palliative care in Africa?
Thank you, Jean. And I want to say that we launched the 2025 Atlas for Palliative Care in Africa during the 8th African Palliative Care Conference, which was held in Gaborone, Botswana, and that atlas is available online. And I want to say that some African countries are making tremendous progress in terms of integrating palliative care within routine care, so that as many patients and families can have access to this palliative care. And such countries include Uganda, Kenya, Malawi, South Africa, and other countries are also making some good progress. They are not yet there in terms of effective integration, but they have services that are happening. They have had people trained, they have champions of palliative care, they have some national associations, and some people supporting the development of children's palliative care. And such countries include Ghana, Nigeria, Cameroon, Burkina Faso, and several others. But I want to highlight an important thing. Even where we talk about countries that have achieved high-level integration, problems still remain. I'll give an example of my country, Uganda, and we ranked top as a country that has achieved high integration, but still there are issues which affect effective access to palliative care. For example, there are health workers who have been trained in palliative care, but government will not deploy them in centers where they can add value or provide palliative care. And then we have situations where the specialty is not being recognized to allow for promotions for people who choose to specialize in palliative care. And then the issue of access to opioids for pain and other symptom management. Some of our clinicians have the opioid phobia and they will not give out the medicine to the patients. And then the fact that the opioids are dispensed at higher levels of service delivery, for example, regional referral centers and health center force, patients have to foot out of pocket costs to go to these facilities to pick the medication. And many of them cannot afford that. So that is the picture I can paint about palliative care. Great work is being done with meager resources, and a lot more still needs to be done.
Dr. Eve, am I right that it's about 90% of the African population who don't have access to palliative care?
Yes, that is accurate. About 10 to 11% of those who need the palliative care actually have access to it. And we need to tackle those socio-economic barriers to service access.
It's a really big gap when you think of how inexpensive in some ways palliative care is to put in place, and how much unnecessary suffering it can relieve. So I think it's very interesting to have different people here who are running different sorts of projects aimed at filling that gap.
And maybe, Jean, I could add something that
Please.
it's important to think about innovative models of care that work for our populations as we think about scaling up access to palliative care. If people need it at home, let's have it at home. If we need to do camps and reach big populations, let's do the camps. If we need to do community outreaches, let's do the community outreaches. Let's be in the hospitals, and let's even use the technology. Do whatever we can to reach the last patient.
I think I think actually we in Ireland can learn a lot from Africa in relation in particular to community care. I was very struck when I was visiting some of the slums in Kampala with Hospice Africa Uganda about the level of community support that was being given. And if I compare that with here in Ireland, where we have quite high levels of access to palliative care, but people, it is medicalized, and the communities are not supporting people in those end of life. So we certainly in the Hospice Foundation and right across a lot of the European countries are working at community initiatives where we can learn a lot from Africa. I also think we can learn a lot from Africa about the integration of spirituality into palliative care, because they are really quite divided in a lot of the European countries. So this is not a one-way street, and partnership is about learning from each other. Tell us a little bit about the African Palliative Care Association.
Yes, thank you. The African Palliative Care Association was founded in 2004. And I want to acknowledge that one of the brains behind the setting up of the African Palliative Care Association was Irish, and that was the late Professor Anne Merriman. And she felt that there was need to have a body that can bring us together to advocate for better access to palliative care in every African country. And the African Palliative Care has been in existence for close to 20 years, and it's a Pan-African organization. It is a membership organization, and we have four main objectives. The first is to increase awareness about palliative care. The second is to ensure that palliative care is integrated into health systems and that it is underpinned by the best available evidence. And then the third is to strengthen the evidence base for palliative care in the region, and also to ensure that evidence leads to knowledge translation and also leads to better and family patient care. And then the fourth objective is to ensure sustainability of the discipline of palliative care and also the sustainability of the organization. And we work with close to 42 member states in Africa on all those four important objectives. We engage policymakers, we do capacity building, we support education, we advocate for balanced access to opioids and other essential controlled medicines. We support country exchange visits to help people gain experience and learn. We do a lot of capacity building for young researchers in the region. We actively engage in research with partners within and across Africa. And we love partnerships. We work closely with the academia, national associations, leading clinical sites. We work with patients, adults and children. We work with caregivers. We work well with donors. And that is how we deliver on
Eve,
our
thank you for being so clear about the work of APCA. I can say, having attended the conference in Botswana last year, that the work they are doing is phenomenal, and it's got a particular challenge in more recent times that the big funders who were putting money into palliative care internationally have taken palliative care out of it. So groups like the One Foundation, who are giving money to Africa for palliative care, and also we've obviously what's happened with American aid, it means that funding for projects is a really big challenge for APCA. But with the resources they have, they do phenomenal work. Now, Eve, I'm going to hold you and thank you for this contribution, and we will talk with you when we get back into the panel and continue learning more about what is actually going on at the moment. So thank you very much, Dr. Eve. Dr. Eve spoke about Dr. Anne Merriman, and if we had been holding this webinar 12 months ago, there is no doubt that Dr. Anne would have been a significant contributor to it. Unfortunately, as most of you I think are aware, Dr. Anne died last May, shortly after her 90th birthday. She played a very important role in developing palliative care in Africa and building a vision for it being accessible to everybody. So she founded Hospice Africa Uganda, which provides a model for how palliative care could be delivered. She developed a model for safe and cost-effective delivery of liquid morphine, and she set up the Institute of Hospice and Palliative Care in Africa, as well as being one of the key movers behind the foundation of APCA. Her massive contribution is recognised by the fact that the Irish government recently announced that it was funding the Dr. Anne Merriman Award for Excellence in Palliative Care in Africa, which is a biannual award with the prize of €20,000, which will be administered by Eve and the team at APCA, and details of how to enter will be announced in the next sort of weeks, month. I am delighted, though, that we are joined by Miriam Donoghue, who is a good friend of Dr. Anne's and who was with her when she died. Miriam is a communications consultant specialising in the development sector. She's chronicler of Dr. Anne Merriman's life, and she volunteers at Hospice Africa Uganda. She's from Kilkenny, but is currently living in Kampala. So Miriam, can you tell us about Dr. Anne's contribution to palliative care in Africa? You're muted.
So sorry. Can you hear me now, Jean? Can you hear me now, Jean?
All good.
Great. Sorry about that. Dr. Anne's contribution to palliative care in Africa has been immense, and it was great to hear Eve outline where palliative care has come. But Dr. Anne, she sowed the seeds when she arrived in Uganda in 1993, having spent a lot of time and given a lot of consideration where she would set up her model of palliative care in Africa. She's regarded actually as the mother of palliative care in Africa, and I think her biggest contribution was sowing the seeds and using her immense conviction and passion and strong belief that the critically ill in Africa needed to have a specific holistic palliative care. That drove her, and that drove the palliative care movement to where it is today. And, it's fantastic to see that, she passed away 10 months ago now. It wasn't tragic. She was 90 years of age, but her spirit is still living on and living really, really strong here. And it's particularly wonderful as well that the government in Uganda is working on integrating palliative care into all its health systems. And it's important that Anne's mission and vision wasn't just palliative care for all in Uganda. She was ambitious that there would be palliative care for all in need in Africa, ultimately. And when she arrived in 1993, there was palliative care in 3 African countries. And when she died last May, there was palliative care in 37 countries. And there's another maybe 18 countries to go. And even on Anne's deathbed, even 2 days before she passed away, in her last conversations with me and others, she just kept saying to carry the mantle, carry the candle, and to ensure that her mission is fulfilled for right across Africa. So she was an immense figure, hugely inspiring, and it was an absolute honour for me, in fact, to have known her and to have worked with her over 10 years.
So, talk a little bit about morphine. Dr. Eve has given us some information, but I know Dr. Anne had a particular model that she really managed to work, which was very creative. So tell us a little bit about that.
Absolutely. Central to Dr. Anne's very sort of unique holistic model of palliative care was the use of affordable oral liquid morphine. When she worked in Singapore, well ahead of coming to Uganda, she was involved actually in setting up the first hospice in Singapore, and she devised there an oral liquid morphine solution, which she made literally at the kitchen sink with a bucket using morphine powder, colorant, and water. And she quickly discovered that this had a huge role and huge impact to play in managing pain. And her conviction very much was really human, was to relieve suffering of people in pain, people who in Africa, particularly who didn't have access to services, to treatments for cancers and other illnesses. So when she arrived in Uganda, she set up hospice. Her first big mission was to get the Ugandan government to allow the importation of morphine powder, because without that she wasn't going to be able to execute the model of palliative care that was her vision. And she worked very hard over a period of months. She connected with the then Minister for Uganda, Dr. James Makumbai, and eventually the Ugandan government agreed to regulate to allow for the importation of morphine, and that was a game changer. For many years, it was still made in hospice, literally at a kitchen sink. But about 15 years ago, thanks to contribution from the American Cancer Society, there's now a little unit in hospice headquarters in Makindye in Kampala, which makes the morphine. They can make 450 litres in one batch. It's a fantastic enterprise to see in operation. And there's an agreement with the Ugandan government whereby the government funds and distributes morphine, all made at hospice, right around the country. It's free for all citizens. And that's all down to Dr. Anne's vision and to her motivation and her strategic approach to how her model of palliative care could work here. And when you look at the very simple bottle of morphine in a plastic bottle with a very simple label, and when you see the impact that has on patients living in massive pain, it's really moving.
It's a wonderful model, and it's one we'll come back to. We have 1 minute more, Miriam. Could you just tell us a little bit about the Institute of Hospice and Palliative Care in Africa?
Yeah, the second main weapon in Anne's armory, number one was getting agreement to import morphine so she could make so that oral liquid morphine could be made. But her second one, and this is how she was so strategic, was to train healthcare workers in Uganda and around Africa to spread the model of palliative care. So she set up a little university on site in Kampala, the Institute of Hospice and Palliative Care, which started training many years ago doctors and nurses and social workers, etc., from right around the continent in palliative care. Today, you can do a master's, a degree, a diploma, and there's also small short-term courses, and about 10,000 people have been trained over 28 years in palliative care in the long and short courses. And last year, we had a wonderful graduation of 33 professionals from 7 African countries. And actually, Jane, 16 were supported by the Irish Hospice Foundation scholarships, which have been hugely impactful. So training healthcare professionals was and remains really important in terms of spreading the model of palliative care that Anne espoused and that she developed.
And we will be coming back to training later on in this webinar. So Miriam, I'm going to leave you there for the moment. Thank you very much for that. And let's move on and talk to a paediatric oncologist from Wicklow who has lived and worked in Tanzania for the past 18 years. Dr. Trish Scanlon, somewhere? You there? Trish, you are extremely welcome. Trish is founder and CEO of Tumaini La Maisha.
Tumaini La Maisha.
You've much better pronunciation, which is Swahili for Hope for Life. And in English, the organisation is called Their Lives Matter. She is Interim Director of Global Health at Children's Health Ireland. And in 2022, she received an honorary doctorate from the Royal College of Surgeons. So Trish, can you tell us about your first visit in Tanzania and how come you've been there for the past 18 years?
Well, I visited in 2006 for 2 months. It's just part of a master's in international health. And I found that the ward, first of all, it was this very, very, very basic ward. It had 17 beds. There was 1 doctor, 3 nurses. But even though they had almost no chemotherapy, but what they had was this like real incredible compassion and love for the children and real dedication to them. One of the conditions, a charity had come on board and was providing the chemotherapy free of charge and a little bit of education. And with that small amount of support, they had moved survival from less than 10% to more than 70%. So for me, it was a proof of concept. It wasn't that people weren't able or didn't care. It was like literally you can't treat children's cancer without chemo and without a little bit of kind of higher support. And so for me, it was inspiring to work alongside these people and see what they were doing in the most extraordinary circumstances. And also to kind of realize what they needed was someone who was loud and brash and a pediatric oncologist, so could kind of fight their corner for them and allow them to do the wonderful work that they needed and could do if they got the resources they needed.
You've done phenomenal work on getting the survival rate of these children with cancer up from was it 1 in 10 to 5 in 10?
Yeah, so for everything other than Burkitt's lymphoma, but they had done this entirely without me, moving Burkitt lymphoma from less than 10 to 70%. But all the other conditions, even though the government itself had pledged to provide cancer care free to all citizens, which was an amazing, removing a lot of hurdles for the care, but still, the resources were very little, and if the cupboards were bare, yes, you could come in and stay in the hospital and get the few blood tests and radiology things that were available. But in order to get chemo, you had to go buy it. And over the last 20 years, in a really collaborative way with the government, with all my Tanzanian colleagues, I'm just one very small person. What has happened in Tanzania, and it's not just in one hospital, it's right across the country. We now have 9 treatment hospitals. And we have 21 hospitals in total in our network, which means the other hospitals, they don't do the active treatment, but what they do is stabilize and transfer. They're the hospitals, the smaller hospitals that see kids early. And so they refer them early. So kids arrive to us in earlier state.
We are focused here on palliative care, so I hate focusing on the unsuccessful cases, but that's what we need to do in this case. So you're not a palliative care specialist, but you have been providing support for these children who are not being cured. So talk to us about how you have done that.
Yeah, well, I mean, I'm not a palliative care specialist, that's true, but I do feel that in many ways, palliative care is good quality care, and really 360, 24/7, making sure that the child and the family are centered at the heart of all the care that we provide, and making sure that the decisions that we make are in the children's best interest, whether it's cure or whether it's palliation in the true sense of palliation. Yeah, so even though we've had great success, and even though, our first number of kids was about 120 a year, and now we've more than 1,000 a year, we're still losing about 50% of the children because we're nowhere near at the number that we think are getting cancer every year. So until we get that full number across the line and into hospital, we'll always have huge numbers of children coming too late. So yeah, it's very, very challenging. But it's something that sadly we're used to, and there's a couple of myths around it, that African mothers care less than Irish mothers about their children. That's absolute nonsense. Absolute nonsense. If a mother in Tanzania thought that standing on her head for 3 months would cure her child, she would do it, and she wouldn't even think twice about it. They care just as much and would sacrifice just as much as any parent anywhere in the world for their children. It's just a sad fact that we as the medical profession are failing the families by not providing the care, the curative care that we know would cure these kids, and reaching the children at the early stage. So it's something that we're still trying very hard to overcome 20 years later.
My understanding is you're working with a network of hospitals that when a child goes home, you are not able to do anything more to cure them, but they are going home. You have a network of right across Tanzania of hospitals who are supported to care for those children so as they can have as peaceful a death as is possible.
Yeah, so when we started, we were in one site, and more children were dying than were surviving. Now it's more or less this sort of 50-50 now. But Tanzania is a vast country, and most children still live rurally. The big cities still are, maybe 30% of the country. And so you're still sending children long, long distances away if you were centering care in one site. And we realized that relatively quickly, that in order to reach them early, to get them to cure, but also rather than just giving them, which we did originally, was giving them a bottle of morphine and sending them home into the mist and not really knowing what happened. It still does happen a little bit because we need to expand our network considerably larger than we have it at the moment. But we do now, as I say, have 21 sites that we've chosen to try and get to the corners of the country, so that now we can send children home, yes, with morphine, but we can send morphine on the bus to them to the local sites. We also can give something called metronomic chemotherapy, which is something that I didn't believe in at all when I started using it. I just thought, rather than send them home with nothing, let's give them some chemotherapy tablets. It'll make the families feel better. It'll make the teenagers feel like they're having some treatment. But we got to the situation where we had lots and lots of children on these tablets who had failed IV first line and IV second line chemotherapy, heavy guns. And 2 years later, they've no evidence of disease. So we've managed to give children back like extraordinary, of course, not all, it's a subsection of the children we sent home, but give children really some extraordinary quality of life. And, they go back home, they go to school, they do everything as they would, and we're able to follow them thanks to our partners around the country.
It's brilliant work, Trish. I could stay talking with each person all day, but we are doing, as we say, a whistle-stop tour of things. So let's go to Malawi and talk about the importance of training in palliative care. So Trevor Corrigan's a GP in Gorey and is part of a GP practice that has demonstrated a clear commitment to Malawi over the past 10 years. He and his colleagues got introduced to Malawi by the Southeast GP Training Scheme, which has a rotation in Malawi. And to the best of my knowledge, it's the only Irish GP training scheme that includes an African rotation. So it's something others can learn from. We have his colleague, Dr. Balwani Mabaka, who is an associate professor of public health at the University of Livingstonia. Ivanica, we have Balwani. Over the past 10 years, since Balwani came back from Malawi from doing his PhD in Hong Kong, he has been working with Trevor and his colleagues on training clinical officers, often using a train the trainers model. Building on Trevor's experience as an SHO in palliative care in Waterford Hospice, they added palliative care to their training agenda and last year ran a training in palliative care for 30 clinical officers. Trevor and Balwani will be working together at the end of this month, running a training in 3 hospitals in Malawi, a training which includes hands-on clinical outreach in palliative care. So, Balwani, why the focus on clinical officers?
Okay, fine. Thank you so much. Hi, everyone, and thanks, Jane, for introducing us with my colleague, Trevor. Of course, yes, you're right. We're focusing on the training, but then you are targeting the clinical officers. These clinical officers, in our case, are the ones who form the backbone of frontline healthcare workers in Malawi. I know, of course, this could be typical of our colleagues as well in Uganda and other countries as well, neighboring countries. And these are the ones who are often in first contact and in continuing care of the patients, including those with life-limiting illnesses. And we're doing this because we're targeting the clinical officers because we have got a very big shortage of doctors in our setting. For your information, like in Malawi, we have only 400 doctors who are taking care of 22 million people in Malawi. And that's a very big gap. While if we compare with Ireland, you find that you have got lots of doctors, 18,200 almost, taking care of only 5 million people. You can imagine. All the time when I look at these figures, I feel like we should just swap. I think we get the doctors from Ireland and work in Malawi so that maybe the ratio can be a little bit more better. So that's the main reason why we are actually focusing on the clinical officer in this case. Another thing is that these clinical officers are well embedded in the communities because they are the ones who are dealing with people in the communities in the health. And in our setting, the majority of the population live in the community settings, about 80%. And these clinical officers are the ones who are embedded right there in the clinical settings. So in equipping them with skills in terms of how to manage these communities, it will be very, very important. And that's why we're trying to target the clinical officers.
Mm-hmm. Trevor, how different is the training it's obviously shorter, but how different are the things that you're training people about palliative care in Africa in comparison with Ireland?
Jean, thanks for having me on. I suppose, look, it's very different. I don't think you can pick up an Irish model and transpose it in Africa. It needs to be tailored and it needs to be adapted specifically for the community, taking into account cultural differences, supply chain issues, resources, availability. Like Balwani has kind of already said, clinical officers make up the backbone of healthcare provision in Malawi. Their training is a diploma. It's around 3 years. And I suppose the partnership developed 10 years ago looking at non-communicable diseases because we're seeing a rise in the likes of diabetes, hypertension, all these diseases that hadn't been kind of resourced or looked at previously. And it was in talking to the clinical officers, talking to people on the ground, that they actually asked us to give training in palliative care. So this isn't something that we transposed. We were talking with our partners in Malawi and they said, look, we would love some formal training in palliative care. So we took that on board. We arranged a training workshop last year where we spent some time going over I suppose the treatment of basic symptom management in Malawi. And bearing in mind there's the same resource issues that everyone has talked about before. And then talk about communication, because that's another thing that you can't transpose from one society to another. There's cultural differences, matriarchal societies, patriarchal societies, being deferential to elders, talking to people who are living in different countries, communication issues, language barriers. There's so much going on. So we're hopefully going over later on this month, we'll do some hands-on work. And really what we're hoping to do is to develop a Bachelor of Science for the clinical officers and really embedding palliative care training in there. And I know there's training logs and everything ready to go. And I think that's really interesting because I suppose going on to what everyone's been saying before, the really important thing is that this is sustainable, that this kind of grows, develops and expands, and that kind of train the trainer workshops are absolutely fine, but they're not sustainable. They don't multiply really. What you need to do is take the train the trainer workshop and then build this out further and further. So the trainers are now trained and now they can go back into the community and train other people and multiply and expand.
One just very quick final thing, Trevor. You were saying that in the training you were doing, you were learning things like the different uses of drugs. You gave me an example, which I think is useful for people to know. This learnings go both ways.
Absolutely. So it's not the only thing that we learned. I think Malawians are incredibly resourceful, adaptable people, and some of that is out of necessity and having to be. We're incredibly privileged in Ireland to have access to so many more resources. But a lot of those are lacking in Malawi. So I know talking to one of the clinical officers, and bearing in mind how different, again, things can be. So you might see later presentations of diseases. So I know we had one clinical officer who had told us how they were managing kind of fungating wounds and didn't have access to kind of the same sort of treatments that we would have with later presentation. So they were having to kind of compound extemporaneously their own kind of paste involving metronidazole or flagyl, along with other antibiotics, and applying that to wound. And using that or applying that to wounds for wound care and having kind of reasonable outcomes and kind of making patients more comfortable. I suppose those kind of issues that don't present as much as in Ireland, where you have these wounds that may be fungating, maybe malodorous, then become stigmatizing for patients and things that we don't consider because we don't have to consider them. And how they've adapted and amended their behaviors and treatments to accommodate that. It's been wonderful to see.
Trevor and Balwani, thank you. Thank you very much.
Thank you.
So our final stop in our, what did I say, is very much a whistle-stop tour of Africa is Kenya. And I'm delighted that we're joined by Sister Anita Hubrich, who is a daughter of charity of St. Vincent de Paul. And that's an organisation, an order that we, of course, know here in Ireland because they founded St. Francis Hospice in Raheny and Blanchardstown. And I'm delighted to see that Fintan Fagan, the CEO of St. Francis, is here with us today. We have a wonderful audience, different countries, people in different roles. So you are all, again, very welcome. So Sister Anita was born on Griffith Avenue in Whitehall in Dublin and is a nurse trained in general paediatrics and midwifery. She has worked in Nigeria and Sierra Leone as well as in Kenya. And for the past 3 years, Sister Anita has been running Our Lady's Hospice in Thigo, which is a 9-bed inpatient hospice, which is based on a medical compound with a small dispensary and a physiotherapy department. Sister Anita, you're the first in-bed hospice we've spoken to today, and they're quite unusual, I understand, in Africa. Why did you decide to go that model?
Now, when the Daughters of Charity came to Thigo first in 2000, they did home visits in the locality to see what the needs of the people were. And Sister Eileen was a daughter of charity who'd worked in Sierra Leone with me, and she was in Thigo at the time, and she identified many people dying with cancer in their homes, in very poor conditions, in a lot of pain. So her dream was to build a hospice where people could come and receive quality care, and it was kind of like a homely place, and they died, with no pain, pain-free. And in 2020, the infrastructure on the roads were very poor due to erosion and cotton soil. Now that in the latter years, now we have better roads coming to this area. So the real reason was seeing people suffering so much and in so much pain. So it was wonderful to see our hospice opening on the 24th of May, 2010. Now it's a small hospice with 9 beds. Now, with our links through, hospices or hospitals in the area, we've linked in with many hospitals, dispensaries, and now we have a referral system for booking because there's a huge demand on beds. At present, our 9 beds are full, and we still have people waiting to come in. We also, when we go out to the community, some people tell us that people have cancer in their home. I visited some people and have been with them until they died in the home, but we haven't an actual program set up yet for home visits. And just a little story to relate about one person who came into the hospice. He was a young man, he's only in his 30s. He has cancer of his tissues, which is very painful. And he came in and he just landed at the back door of the hospice. And I thought he looked very sickly, and I invited him to come in up to the office and just to share his problem. He said he was attending Kenyatta Hospital and he was due to go back there, but he was on no pain relief, and I could see the pain in his face. He was in agony. And I said, "Are you on morphine?" He said, "No, I'm not." I said, "When you go back to the hospital, please ask for a prescription for morphine or get it." But I said, "I will give you morphine today, and then you will come in and you will get it again." I gave him enough until he went to the hospital in a few days' time. Now, since then, he's come in for admission to build up his nutritional status. And it's lovely to see him because he's the most beautiful smile and he's so grateful for everything. And to see him now pain-free is just wonderful. And as somebody was saying, and I agree, that morphine, the sister that initiated the program made the morphine at the sink. When morphine has been scarce here in our area, KEPCA organized to reconstitute the morphine and send it out to us, and that we could get it, free of charge from them. So that was a great help as well for patients. It can be difficult to get morphine, therefore many people have to get a prescription and buy it and come in with it. Other times it's available and we can buy it. So, morphine, as we say, is very good for keeping people pain-free, but in liquid form or morph, it has to be given at a specific time to keep it in the bloodstream and to keep them pain-free. So therefore, we agree with oral morphine is working very well for our patients. We also have a clinical officer. I was glad to hear about clinical officers being trained. Clinical officers work well here in Kenya as well. And we have one in our clinic who also looks after patients in the hospice. We had another man, and he came in, and I just don't like people being given false hope. He went and he had actually cancer of his spine, and he was told he needed orthopedic surgery to strengthen the lower spine, and that would help him to walk. Now, I was put in a very awkward position because he went on a Friday, and I met him on the Saturday morning, and he was smiling and said, "Oh," he said, "I just have to raise 200,000 for my pins and plates. I'm trying to get that money organized because on Tuesday I'm having surgery." So I just said, "Now, I'm using the name John, that's a fictitious name. John," I said, "that wouldn't be the right treatment for you at the present time." And he said, why, sister?" So I had to tell him, I said, "I'm really sorry to have to tell you, but you have stage 3 to 4 cancer, and having surgery would not help you at all to walk." So then he said, "Sister, I'm so grateful you were honest with me and you gave me that good news. Now I don't have to look for the money, and I pray that God will help me to recover some ability." He has gone home from the hospice since. He sent a little video clip back to us, and he's walking with a stick, smiling on his morphine. And the family keep in touch and said, "Sister, when he's near the terminal stages, can we bring him back? He wants to go back to the hospice." So we said yes. So, that's kind of, people come in for respite care as well and go home. Now, we had a demand initially. I heard somebody talking about, the diseases like diabetes, hypertension. Some people, when we had, fewer beds and strokes, we bring people in for physio and to kind of help them to stabilize their hypertension and diabetes. But now the demand is very much for cancer patients, and having only 9 beds, we have to prioritize cancer patients.
It's clear with the small number of beds, you're doing massive work. And I love these stories that really bring it to life, what a difference this is making. We are going to keep going. So thank you, Sister Anita. We had 3 objectives when we set up this webinar. The first was to build awareness of the need for palliative care in Africa. And I think all our contributors, but particularly Dr. Eve, have done that. The second one was to highlight the range of Irish African initiatives that are improving healthcare in Africa. And the contributions were all very short, and I'm really sorry for that. But hopefully they give you a feel for the great work that's going on. And there are links in the chat if you want to learn more about any of those. And the third was to begin to explore how Ireland's contribution might be strengthened through effective partnership. So the last 15 minutes is focused on a group discussion about that issue of how we strengthen those partnerships, and also bringing in the panel to answer the questions that you have raised. We are also being joined by Cara Munn at this stage, who I hope will tell us a little bit about the Irish Global Health Network and the work you've been doing to help amplify. Ivana, I think you could bring everybody in as well at the moment. Cara.
Great. Thank you so much, Jean, and thanks to our panelists. It's actually been incredibly powerful to hear the amount of work, the breadth of work that is being done on this issue by many different actors, both on the African side and the Irish side, and the evidence for real partnership that is taking place, where there's mutual learning on both sides. So it's really been fantastic from that perspective. I'd also just like to acknowledge that many of the people attending this webinar are from any number of different African countries. They've been adding into the group, and it's just really, really great to have that together here today. Just for those of you who maybe aren't that familiar with the IGHN, we're an independent network of people from different backgrounds, sectors and disciplines. And what we're most concerned about is health inequalities and issues that impact on the health and development of populations at a global level. So our members include many clinicians, academics, NGOs, policymakers, and our partners from low and middle income countries who really are at the heart of what we do. I'd also say that students and young professionals are also very important members of our network as well. So our core role is around networking. So linking individuals, bringing together organizations who are maybe working on the same issues but haven't had that contact with each other to date. In practical terms, that can be convening a space, like for example today, and allowing these kinds of conversations to take place. We also place a strong emphasis on learning and knowledge exchange, and we have a really strong social media presence that helps us to connect people in that way. So we've about over 4,000 members, so that supports this function of learning and knowledge exchange. So in terms of our event here today and thinking about palliative care, we will be hosting the recording of this webinar on our website, along with resources from our contributors. And we can just have a dedicated web page and just really share information that we feel will be useful to the group, including those that are listening in today. And I think really going forward, it will depend on this discussion, Jean, and what our panelists have to say next. But if there is, some sort of an interest around building a community of practice around Ireland African partnerships in palliative care, then what I would encourage is people fill out our evaluation form. And within that, we just ask the question if you'd like to leave us your email address, so that we can make contact with people again on this particular issue, so that if there is further action to be taken, we can bring this same group together and further discussion. I kind of feel like we're scratching the surface here, Jean. We've done an amazing job, but there's really a lot of depth and a lot further that we could go with this. And so I'm really interested to hear now from the speakers if what they feel could be the next steps, or if there is this appetite for further collaboration. And look, we'd be delighted to support it if there is. Thank you.
Brilliant. So let's talk about collaboration. And are people here, or are people on the panel hearing things that they're going, oh, that would be interesting. We could learn from that, or we have something that might be of help there. Is there, it's those sort of, and in fact, Trevor and myself were talking before the beginning, and we were discovering several places where we had talked about, which had now led to further things. So in the background, my background is global business, and there we did an awful lot of what we called stealing with pride, where you saw something being done well in one country, you took it, you adapted it to your country, and you got all the benefits, and you did give credit to the people who originated it, but you took it and you used it. Are people seeing any of those sort of things coming up? I mean, Dr. Eve, have you heard anything here that you think, oh, that would be interesting for other members of the African Palliative Care Association to hear about?
Definitely the Merriman model, the SYNC model for oral morphine reconstitution is a big bang. And I would really love, where possible, every African country to have an opportunity to do local reconstitution and meet the needs of those who can't afford the imported options. And then the clinical officers thing really struck me. I haven't seen lots of scholarship opportunities for clinical officers, and yet they hold power in terms of decision making. In most cases, they are next to the doctors. Therefore, I loved listening to that initiative of focusing on the clinical officers, because I know in the end, important decisions will be made quickly and they will be appropriate, and we have more of them in primary healthcare settings.
I was very struck, Trish, by what you said about this is good medical care, having palliative care as part of it. And one of the things that came up when we were talking about this was, palliative care is not a specialist, should not be a specialist thing. It needs to become a generalist thing so that it is part of everything. And in fact, there was a suggestion that we should be saying to Irish Aid that where they are funding medical projects, that they should actually be saying, they should be asking the question, is there a palliative care part of that? Because the idea of working with people and then if you're not successful, sending them home to die without any support seems to be a very cruel way of handling it. Is there anything you'd say in relation to that, Trish?
Well, what I would say, just in terms of this webinar, as you say, it scratched the surface, and there's probably lots of clever things that people are doing that we haven't even had a moment to discuss. And it would be lovely to maybe have, top tips from all the experts. I do think also that not just the panelists are amazing, but also just reading all the comments of all the people who are listening. It seems like you have an incredible audience. I was very happy to see my friend and colleague, Christina, who is our palliative care specialist in Tanzania, is in the audience, and we are in the process of creating a course for pediatric palliative care. And maybe I would just reach out to if there's anybody who's on the panel or who's listening who has an interest in that. It's obviously something that it's better to borrow, as you said, or what did you say? Steal with
pride.
Yeah. So if these kinds of things are already available and can be adapted, it makes everybody's life a bit easier. Somebody I think also mentioned, if there was a web page where these kinds of initiatives could be stored and accessed in an open source way, I think that would be fantastic as well.
Thank you. Miriam.
Yes, thanks, Jean. I know a lot of these activities, it takes money, and I just thought I'd take the opportunity to let everybody know about an Irish fundraising initiative for palliative care in Uganda, which is taking up most of my time at the moment here in Uganda. There's a group called Hope on Wheels, who we are bringing 11 now ambulances for palliative care to Uganda. Shipping them to Mombasa, travelling by road with celebrities into Kampala, partnering with the Palliative Care Association of Uganda. The group, they have great ambitions. They have a target of raising €500,000, something that makes me very nervous. It's costing me some sleep at night time. But the idea is that this money would be distributed through the Palliative Care Association under various headings, including that really important area of training and development. And you mentioned, Patricia, the need for clinical officers to be trained up as well. So hopefully this will ease that. There's going to be money for children's palliative care, for more outreaches, and specifically to increase the numbers reached rather than fund current services. And if this is a success, the ambition is to widen this in future years and to do this fundraiser, not just to raise money, but to raise awareness for the palliative care needs in Africa. So I thought it was timely to just to let people know about that. Full details will be launching in March. But I think money is and financial support is hugely important for all that everybody here on this call is doing to advance palliative care.
Thanks, Miriam. That's very helpful. There are quite a number of suggestions in the chat. People offering to help people and saying perhaps we have something that we can help. So Michael Corliss in relation to the Institute of Palliative Care and Hospice in Africa, Uganda, was offering Trevor that they might be able to help. We don't have time. I'm conscious we are going to get you finished in 4 minutes so as you can get back to your busy days. I think what we will do is we will copy these and paste them, and then we will try and reach out and make sure that those offers go to people. And ones that are more generalist, Cara and Ivana, perhaps we can put into the follow-up mail that will have the recording. We would ask you, if you can, either now or when you get the follow-up mail, to fill in the survey. And in particular, if you are interested in being part of a further conversation, to indicate, otherwise we can't, GDPR, actually reach out to you. So that would be really helpful. I would like to land one particular question which has come up, which is around the barriers to palliative care in Africa, the ones around sort of religious and cultural barriers that you are seeing. Who would like to answer that question?
I'm happy to go first.
Good.
Yes, I think one of the barriers I see is the lack of awareness about palliative care not being synonymous with end-of-life care. That lack of awareness largely contributes to late referrals, and then the phobia patients and families have towards palliative care. It also shapes the narrative of how our clinicians make referrals to palliative care. Someone may make a statement like this one: "There is nothing else we can do for you. Go home, go to the palliative care team." And I'm saying, in palliative care, we do something, and we do something important, massive, and a game changer for quality of life. So don't tell a person that there is nothing we can do for you. Potentially, palliative care is more useful for your current condition. So we need to address those cultural issues so that—
Olwani, would you like to have the last word on this issue?
Well, thank you so much, Jean, and thanks so much, Namisango, for your comments. Of course, she has more like wrapped it all, but I think the last word that I can say is I think we just have to emphasize so much on the awareness and community involvement on this. So through community involvement and awareness, I think we can actually deal with most of these barriers which emanate from the social, cultural, and religious beliefs.
Thank you very much. I think we could keep talking all afternoon, but we have promised everybody we will get you back to work. Thank you all so much. Thank you to everybody who has come and watched. Thank you to our brilliant contributors who in a very short time, I think, have given us a flavour of a lot of the initiatives and a lot of the creativity and the commitment that is going on. Thanks to Cara and Ivana at the team of at the Irish Global Health Network for all their work in making this happen. And I hope this is the first of many discussions about African-Irish partnerships in palliative care. Have a good afternoon, everybody. Thank you.
Thank you.
Thanks,
Bye.
Jane.